It is always fun having you on, Dr. House. So, um, welcome everyone. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston. I'd like to welcome you to today's GlomCon seminar. Today, our talk is titled "Viral Kidney Pathology Gone Viral: A Renal Biopsy Conference." Our speaker today is Dr. Jean Ho.
Let's do this really quickly. Thank you very much for spending your Sunday morning with me. I was intending to do this from my office, but it turns out that today is the LA Marathon, so all of the streets are closed, so I'm coming to you from my kitchen here. Today's topic is a selection of cases. I like to do things by themes, and I thought that viral-induced kidney disease would be a good one. It's beautiful pathology. These are classic cases. All of these are actually from our own archives, although not all of them were ones that I signed out, and I'll give credit to my colleagues when that is due at that point. This is very open, so if you have any questions, please feel free to stop me. I don't think I'm going to have a chance to look at the chat box, but I will certainly take a look after the meeting is over and try and get back to any questions that have been asked. So with that, we're going to start. There are many different manifestations of viral infection in the kidney. There's 3 different compartments that we always think about: the glomerular, the vascular, and the tubulointerstitial. Some viruses have the ability to affect any one of these compartments, some of them all 3, like HIV, for instance, where you can get tubulointerstitial involvement, vascular involvement, and glomerular involvement, while other viruses tend to be more glomerulocentric, like HCV and HSV, for instance. So I am going to be concentrating today on a number of viruses, but notably absent will be HIV and SARS-CoV-2, mostly just because I feel like HIV infection has been covered extensively already, and I think all of us are we've had more than enough of COVID. So I'm going to be talking today not about those 2 viruses, but additional viruses that may be a little bit more obscure or less known. So there are many different ways that the virus can affect the different compartments of the kidney. There are direct mechanisms, for instance, HIV, which directly affects cells of the nephron in the glomerulus, or the tubular interstitium, where HIV can affect tubular cells directly. Or there are indirect mechanisms of viral injury, notably, for instance, like the cytokine storm or the inflammatory response seen in COVID infection, or for instance, the body's eliciting an immune response against the antigen, in this case, immunoglobulins, which can then indirectly or secondarily deposit in different compartments of the body, including the kidney, which is what you see in cryoglobulinemic glomerulonephritis. So with that, we're going to start with virus number 1. I'm not going to tell you what it is yet. This is the clinical history. All the clinical histories are going to be fairly brief, and I'm going to be concentrating directly on the glomerular compartment that shows the involvement rather than going through the entire biopsy. I might have been a little bit optimistic about the number of cases and viruses that I can show today, but I'll move pretty quickly. And again, if there's any questions, feel free to stop me and let me know. So the first case is a 56-year-old homeless male with a history of IV drug use. He presents to the emergency room with fatigue, shortness of breath, and edema. He was found to have nephrotic range proteinuria, about 5.7 grams. His creatinine at the time he came in, and again, we don't know baseline here, was 2.9, and his albumin was quite low at 2.1. They did a renal ultrasound that showed mildly enlarged kidneys bilaterally, but with that famous echogenic kidneys consistent with medical renal disease. Nobody really knows what that means, but that's also what they found. Interestingly, his liver was also enlarged with signs of what they call fibrosis, although they never did a liver biopsy. So homeless male comes in with nephrotic syndrome, basically, and AKI with enlarged kidneys and possible liver involvement. So before we get started, I'm going to set your eyes to a baseline with a normal glomerulus. And this is what a normal glomerulus looks like. So let me just show you some landmarks so you can burn this into your mind, and then you can see how different the different pathologies are and where they involve the different parts of the glomerulus. So here you have Bowman's capsule along the outside, if you can see my arrow, and this is the glomerular tuft within. So first off, working from the outside in, you've got your urinary space or Bowman space here, which should be clear. There should be no cells or nothing in there. If you start seeing cells, you got to start wondering or worrying about a crescent. Your glomerular basement membrane should be single contoured and delicate, no double contours. There should never be any breaks. These are all continuous. Where the glomerular basement membranes, they swing around and they anchor, these are your mesangial areas, and they should look like this, meaning you don't even notice them. You've got maybe one cell here, one cell here. If you see 4 or more cells, that's mesangial hypercellularity and indicative of some sort of pathologic process in the mesangial area that's inciting this proliferative response. Again, moving inward. So this is your glomerular capillary. You've got endothelial cells here, which are they're flat, they're quiescent. If they become injured, they can become quite swollen. Sometimes they can take up almost the entire volume of the entire capillary loop. And then inside here, the capillary lumen, aside from red cells and occasional trafficking leukocytes, should be clear. You should not see any proliferative response within the glomerular capillaries. And if you do, that's endocapillary hypercellularity. And again, that's a sign of pathology. So this is a normal glomerulus. Our patient's biopsy, however, look like this. So this is an H&E stain, and I'm going to orient you. So here's Bowman's capsule on the outside, and this is the glomerular tuft on the inside. Now, this is an H&E stain, which is not great for looking at fine detail, but I like how the H&E highlights these aggregates. So this is a glomerular capillary here, and it's completely occluded by this eosinophilic, really dense material. Several capillary lumen are actually occluded, and you have this inflammatory response here, probably with some neutrophils and other white blood cells. We don't know where in relation to the GBMs they are quite yet, because it's an H&E stain, but there does appear to be at least segmental intracapillary occlusion by these aggregates. Here is a trichrome stain, again, in a different glomerulus, showing you now the aggregates, which are eosinophilic before, are now fuchsinophilic or red. Several capillary loops, again, containing this fuchsinophilic material. Here's a silver stain, which I think is probably every renal pathologist's favorite stain, because you can really begin to see the detail of the underlying glomerulus. So again, you have those intracapillary aggregates, which here are kind of muddy brown. And then here you can see the capillary lumen are often occluded by these trafficking. Some of them are neutrophils, some of them are white blood cells, some of them actually have larger nuclei, and we'll get to those in a second. Other glomeruli look like this. So this is a very proliferative glomerulus, but the main thing that I wanted to show you here are what double contours, right? So here is a GBM here. Here is a second GBM right underneath. So you got what they call tram tracking, or membranoproliferative features, which is not a diagnostic term anymore. We use that as a histologic term, meaning glomerular basement membrane duplication. And in some of these loops where there are double contours, they're actually involved with those same muddy brown aggregates, subendothelial aggregates associated with these GBM double contours. So you have a focally membranoproliferative pattern of injury as well. Here's another glomerulus that looks a little bit different. So it is quite busy. And the capillary lumina are, again, occluded by cells, but these cells are a little bit different than your typical white blood cells or neutrophils. First of all, they have larger nuclei and they have abundant cytoplasm, this, kind of pale pink eosinophilic cytoplasm. So there does appear to be some sort of intraglomerular infiltration by a cell type. And, I know, and, a lot of pathologists know just by looking at this, what type of cells we're looking at. These look very much like macrophages. So there is a stain that we can do. It's an immunohistochemical stain for CD68, which is a macrophage marker. And you can see in the glomeruli that there is a really prominent intraglomerular macrophage infiltration, which is actually quite unusual. But in the setting of this particular diagnosis, it's something that we commonly see. So we have a proliferative glomerulonephritis, membranoproliferative features, and macrophage infiltration. So let's go to immunofluorescence staining. And what we see, this is IgG and IgM, and you can see diffuse glomerular staining for IgG and IgM, not only in the mesangial areas here, but also you see these denser aggregates here. These are within the capillary loop. So those are those aggregates that we were seeing by light microscopy. Those are staining very brightly with IgG and IgM. So those are immune complex or immune aggregates, actually. Kappa and lambda light chains show that they were actually polytypic, so we're not dealing with MGRS or a plasma cell dyscrasia associated lesion here, because it stains not equally, although it's stronger for kappa, it is also staining for lambda. So you have a polytypic light chain pattern of staining with IgG.